You know, I've heard, forgive me, but I've heard the term magic being defined as the art and science of changing consciousness at will. Interesting notion, that those magical moments in life where we're going to go, wow, it feels good to be here. So we're going to call in some of that magic today. And Bill is certainly somebody who brings the heart, the mind, body, and community together in ways that I've never experienced. So I'm really honored to have Bill and his protege Tristan here with us today. So if we can welcome Bill, thank you.
And they were saying you have to learn to talk better about you. And so he was warned by the Creator and the ancestors that you have to change, you have to be more verbal. You can't hold it in any longer. And he didn't. It was hard because you're not from here. You didn't have the social mechanisms to drive. But these are artificial. They can and must be recreated in different forms, which is, I think, what some of you are looking at. It can't be straight academic either. He was a significant academic. He had a master's degree in sociology and stats. But he didn't know how to talk. He didn't know how to say, I love you, I love myself, I love who we are, let's talk, let's be together, let's have fun, let's have joy, let's know we belong. Thank you for the invitation to come. It's an honor to be here. This trail that you're on is a long trail. Sometimes it can be a hard trail. But I'm hoping that, basically, I'm not hoping, I know that in your work you will end up helping people in stronger ways than you will ever know. And that with each day that comes, you have to know the joy. You have to know the joy and excitement of being young, of being talented, of being rich, and being kind and generous. This is a short version of the song.
We're doing, this man embodies, and he's been a guiding light for all of us who've been in the SDH program, and you'll be hearing more about that later. So please welcome Dr. Michael Hayes.
Thank you very much. Bill, you were very hard at to follow. And I don't know if I'll do this justice. I actually, when I think about this title, I probably should have called it Meanderings of a Decrepit and increasingly mad professor. But it's our quest. It's really to try to understand the simultaneity of all these different factors that take place. It's an impossible thing to do, really, which is part of the reason why it will always be contested and will always need people from different vantage points to be thinking about it. It's not a unified theory of something that can be reproduced, understood straight up, and be unproblematic. There's a lot going on in here. And you know what we want to try to do, at least what I would hope that the university community would want to try to do, is to stimulate our ideas about how these things work, and to take meaning for ourselves about how they operate in our lives. But to see that against not just the imaginings of our heads, but somehow the correspondence between that and what we see in the world. Because if we don't do that, then this could all be completely evidence-free. We can all go home and make it up and just live our lives. So we need to we need to interrogate these ideas, but I would hope we would do so for a purpose, not just for our own entertainment or amusement, but to think about, because this is only half the equation. This is just the sort of academic side of what it is that's going on. On the other side of it is, in the face of this, what are we going to do? What are we going to do to help to alleviate suffering? What are we going to do to help to improve people's ability to be in the world in a positive way, in a way that they feel loved, respected, part of a community? Because ultimately, that's the key. I think about what Bill was saying about remembering the joy, remembering the energy, remembering the inquiry, remembering all the things that are part of this human experience that shape us so profoundly. And of course, obviously, impact on the ledger of our lives in the Register of Health. And we're all in it. You know, it happens to us every else. And she can strap off me. Why is it not biological? Why is it not environmental? You know, and so forth. And she was right, you know. Well, I don't know. It's a good question. So maybe there's a time for a rethink. I'm not sure. On the other hand, point number 3, other kinds of conversations. Why not social? Particularly in the context of service delivery and policy. Why not social? It's fundamentally social. Our experiences of illness and so forth are profoundly social, even though those experiences are shaped by environment and biology and our social position. But why not social? That social seems to be the big missing thing in what we do these days. When we think about biomedicine, it's about the disease, it's about the patient, it's about the magic bullet that's going to somehow cure people. We don't ask questions, well, how did they get there in the first place? You know, we have no ability, it seems, to get purchase on this idea that, you know what, when you start life in poverty, it usually ends prematurely, and along the way, it ain't fun. Why don't we get that wisdom? You know, I've been in this game for too long. When I started my master's degree, I was fortunate enough to meet a couple of incredible people. One of my classmates was a guy named Clyde Hertzman, who had just an enormous influence on my life, and I am so proud to say that he was a great, great friend. And, you know, gosh almighty, you know, he was so smart. He would start talking, and out would come on these floodlights of just incredible ideas. And my response would be like a 60-watt bulb. But Fraser Mustard, you know, and Clyde and I were in this very first graduate seminar that Fraser organized called Population Health. And it was posing the question, why do we have these gradients in health outcomes? What's going on here? And you may recall that the book that finally came out of that discussion was called Why Are Some People Healthy and Others Not? Parenthetically, the book never actually answers the question. Also, parenthetically, it was just a collection of loose essays. To my mind, the conversation about how do we understand this didn't really begin until Richard Wilkinson wrote on Fairly Structured Society. But you know, there was a narrative there about how this actually happens. And we've known about it now for a while. In 1974, the Lalonde Report said, health does not equal health care. Oh yeah? Tell that to a politician. Because, you know, we did a study in the mid-2000s in the Telling Stories Project, where we analyzed newspapers, both French and English, all stories about health, trying to figure out just what proportion of them actually engaged in the idea that there were social gradients or that health was structured as a consequence of our experience in our social position. And it turned out that less than 1% of all the stories that we analyzed, somewhere in the order of 12,000 stories, less than 1% actually had it. And those few stories were actually letters to the editor, because Richard Wilkinson was speaking at the University of Alberta, and a couple of letters talking about social gradients and so forth. Now that was, you know, that work came out in 2007, 2008, but I don't think the world's changed very much. So how is it that we've had this discourse, if we started with Lalonde, that's now 40 plus years old, right? 41 years old. And yet we still seem not to have the ability to understand this. That it's the social that needs to be addressed. And in fact, if you think about just the events yesterday, think about the exacerbation of all of this. Because, you know, we're now going to let folks who make incomes like mine put in twice as much money into long-term savings under the guise that it's just regular families who like to do this sort of thing and so forth. It's crazy making. It's absolutely crazy making. We will fund healthcare to the nth degree, and we forego housing. We forego poverty, particularly child poverty. We forego so many other things that actually shape our experiences. I mean, it's almost like a factory to produce illness with the shareholders being those people who provide the services. And that's a terrible thing to say. That's very, very cynical. And I don't really believe that, but I'm trying to make a point here. And that is that we seem to have organized ourselves in this crazy way in which we actually just want to reproduce disease because it provides a lot of different jobs and it drives the economy, instead of just thinking about some of the wisdom that Bill was sharing with us, but actually just caring for one another, just about being in our culture in ways that are helpful, positive, joyful, reflective, humane. That just seems a little bit strange. So I think there are 3 different conversations that need to be connected around this program.
So we're going to start with Deborah Sheets, Perceptions of Remote Monitoring Technologies by Clinicians and Family Caregivers. Secondly, we have Lynn Belle-Isle. At the table, people who use drugs, how is power in decision-making being shared? Next, we have Samuel Ofori, the impact of interpersonal relationship characteristics on dimensions of health in 4 sub-Saharan African communities. Then we have Marian Selfridge, Making My Way to Knowing, Street-Involved Use of Digital Technology to Access Information Online. Then we have Licia Rodriguez, Exploring the Impact of a Community-Based Arts Program on the Social Inclusion of People with Dementia. Then we have Sumiko Yonida, Association Between Cognition and Personality Change in the Oldest Old. Then we have Renee O'Leary, OMG, What Have I Walked Into? The Ugly Public Health Debate on E-Cigarettes and Vapor Devices. And then Selena Davis couldn't be with us today, but presenting on her behalf, we have Dr. Abdul Rudsari, Development of a Computerized Poverty Intervention System for Primary Care. Ingrid Hanofsky cannot be with us today as well. And then lastly, we'll have David Guibault, The Journey to Canadian Adulthood.
Are working together to integrate technologies in a way that hasn't happened before to help older people flourish in their homes, which is where they want to be. So one of the limitations of current technology approaches is that it focuses on things like biomedical issues, like are they getting their medicine? You have medication dispensers that operate completely independently from ubiquitous remote sensors that tell you whether or not your mom has opened the refrigerator or walked out the front door, things like that. We're interested in understanding what are the barriers and challenges to adoption of technology, but most importantly, and that's not reflected here, in integrating these technologies in a way that can give us more meaningful information that's continuous data in a remote way, and in a way that's very non-obtrusive, like we're not talking about video cameras or anything like that. So what we're interested in doing with these continuous kinds of monitors, what you can do then is look at intra-individual change. So you can see an individual, the change that's happening by comparing them to themselves. And you can look at rates of change.
Even more specifically, illegal drugs other than cannabis or marijuana. We have drug laws that criminalize people who use these drugs. And throw in factors like poverty, housing precariousness and homelessness, mental illness, and discrimination for various reasons, and disproportionate rates of HIV and hepatitis C. And you have a group of people that are highly stigmatized, probably the most vilified in our society, frankly, and are excluded from our society. Well, there are some of us trying to address some of those issues. One way to do that and to try to address those inequities is to include people who use drugs in decisions that affect them, decisions related to research, policy, and to service delivery specifically. And so in my work at the Canadian AIDS Society, I've been adhering to the concept of nothing about us without us, and doing this work. However, waiting awkwardly through this work as I did it, trying to figure out how to do inclusion well. And so I decided to do this for my PhD research. I partnered with the Society of Living Illicit Drug Users, a group here in Victoria, as well as the Drug Users Advocacy League in Ottawa.
Because of those social changes, now Africa is becoming moving from the agrarian, which tends to bind people, to the industrialized economy, which tends to separate people. So people who used to have old friends in their villages, nowadays these old friends have moved to the cities. And how can they manage their interactions with them? They have to first maybe you have to adopt the new technology by having phone, and it is not easy to even buy a phone. And even if you have access to a phone, how can you use it? It's very challenging. I'll give you one typical example. My mother used to call me all the time, and recently I would say that she has given up because she tells me that whenever she calls, someone picks the phone, and she thinks that maybe that person is preventing her from contacting me. And who knows, do you know what? It is the answering machine, because when I'm not there, it's the phone. And she thinks that someone is there trying to prevent her from reaching her last born, which is creating a very big inconvenience for her. So I don't know how even this is affecting her health, which I know.
Youth primarily described using a combination of phone, text, private messages, and Facebook wall posts to connect with friends and family. 94% use Facebook Connect to People. They're also active producers of social media, creating blogs, writing updates, posting photos and videos. Street-involved youth are also engaged in participating in popular culture and media, watching movies, including porn, listening to music, and using digital technology to buy and sell. They're exposed to the same corporate messaging, ads on Facebook and YouTube, music videos, and celebrity stylings. Youth reported looking for information and resources on housing, jobs, health, including psychiatric medication. With just 22% regularly going to school, I'm curious about how much of the ways they learn about and make sense of the world is online. 15% signed petitions or engaged in activism. This exploratory data suggests that street-involved youth's online research and communication may be a key means by which they negotiate and temporarily transcend the challenges of their daily lives. This opens us up to a conversation about how they make health and other decisions based on the information they learn online.
We still need to understand better how these interventions enhance social inclusion. So that's really my interest and my goal. So my interest is really to explore the relationships between subjective experience and the potential of community-based arts programs to increase their social engagement. And in my opinion, community-based arts programs, we need to see these interventions as a non-clinical community resource in dementia. So that's really my interest. So understanding how arts-based programs could be employed with community-based organization is crucial to really incorporate concrete interventions to increase our whole community's health and well-being.
So study one looked at personality change prior to dementia diagnosis using a subset of individuals from the Octogen data set that eventually converted to dementia. We identified a longitudinal pattern of personality change prior to dementia diagnosis. So individuals showed a significant increase in neuroticism preceding dementia diagnosis. The aim of study two was to expand on study one by examining trajectories of personality and also domains of cognitive functioning. So we ran bivariate correlations between each personality trait, so extroversion and neuroticism, and each domain of cognitive functioning. So information processing speed, episodic memory, and fluid intelligence. For these analyses, instead of using time to dementia, we used time in study. And although we did not find a consistent pattern across all domains of cognitive functioning, our analyses revealed an indication that levels of neuroticism increase as memory scores decrease. These findings suggest that personality change, specifically increasing levels of neuroticism, may be associated with cognitive decline and may be an early indicator of dementia.
Over here, Michael Siegel, head of Boston University Public Health, says the CDC, the Centers for Disease Control, are running a dishonest campaign. They are spreading lies, dishonesty, and deception. We're not talking about evidence. We're saying that the CDC is false. Oh my heavens. And if you think these guys are bad, wait till you get to the e-cigarette people who weigh in. If you're against e-cigarettes, death threats. That was a noose that was sent over to 2 people, including Dr. McKee over here, saying, look out, your days are numbered. Oh my heavens. It gets worse. Okay. They say that vaping is not a public health hazard. It is only a hazard to public health funding. You're trying to protect your job.
We designed a knowledge-based electronic system to address poverty in 3 steps, integrated into the screening, included as a key risk factor and intervened by asking patients 8 questions about living in poverty. There was a paper in, I think, 2011, which had questions about poverty to assess the level of poverty. We leveraged that paper, which was developed in DC, and I think it's it was quite, is tested using 150 cases. For the system development, we used open source expert system shell. These are the computer systems that you don't have to really program a lot. Most of the logic is in there.
This is the 2013 infographic of the Victoria Healthy Youth Survey. It paints a portrait of youth today in Canada and abroad. So what is the Healthy Youth Survey? It began as a Community Alliance for Health Research project, funded by the Canadian Institutes for Health and Research in 2001. It's a longitudinal survey that followed youth as they transition to young adulthood, or to adulthood across 6 waves from 2003 to 2013 in 2-year increments for 6 waves. It's one of the few surveys in Canada to examine the topic over such a long period of time, and with so many youth participating from start to finish. So this infographic here is a summary of 477 young adults who participated in the survey ages 22 to 30. They were interviewed in 2013. This is their data, their achievements, and their lives. The survey initially began with 664.
Who was a researcher at the Smithsonian. You remember?
Right.
Yes, and along with really inspiring modules in that course by people like Alec Ostry and Bonnie herself, Eric Roth, Scott McDonald. And I was able to talk about things like epidemiology of ancient populations, traditional healing methods, that's a module I gave with Nancy Turner, Western medical tradition and context, and also reception and clinical trials and patients' rights. That year ended with, okay, this is still the case, student presentations at the end of the core course. Super inspiring, as is the work that you're continuing to do. And so I really thank you for your ongoing work and for allowing me to be here to hear what's going on now.
I think that we could have, and I sort of came out of it with a lot of recommendations that that could smooth out, or could have, and hopefully have smoothed out over time. We had some initial struggles around student funding. Our students were not eligible for TAs under their department because they'd come in through, under their faculty, because they'd come in through social dimensions of health. And we, as social dimensions of health, had no funding for student TAs. So, so there were some issues to be worked out with that. Took a semester or two, and then students did come in under their own faculty advisors area for TAs. Though they remained not high on the ladder for funding because they were not students. So the struggle between faculties and this integrated program was not trivial at the beginning. And I'm sure there still remains some issues in that way.
But in the spirit of egalitarianism, I starve everybody equally.
Yeah. I think we also, at that time, were just at the edge of bringing together faculty who were supervising these students, and there was a lot of, I think, mystery about, you know, what on earth am I supposed to be doing in sort of co-supervising, or supervising and not supervising. What am I doing as a supervisor of a social dimensions of health student? And I think, you know, we were trying to bring faculty more in to that process. So when we sort of demanded every student write an SSHRC proposal for the experience of doing that, not every faculty member who was supervising them really appreciated that initiative, but never mind.
Now, what is the social dimensions of health? And this is just the definition that I came up with in terms of when I thought about what to write. And I said social dimensions of health is the link between all disciplines to come together and inform each other about the importance of working in a health environment. By being in a program with a wide variety of expertise that range from public health services research like myself, to HIV and AIDS like Birch, to aging like Taylor, childhood obesity like Jen, and also arts-based theater like Trudy, these are unique strengths that we have to pull from. And just one evening, we went out and we had a discussion of over a year ago, just about what we were doing in the S-Stage program, what our research was about, and we're like, oh my goodness, where's the avenue for us to discuss this beyond the classroom, beyond our coursework? And that's when Birch's like, how about a conference? And then we're like, why not bring it together? No one has done it yet. So all 5 of us really got together and have been working countless hours, lots of meetings, lots of planning to bring this together for you today. And we hope that this event is just the start of the conversation and continuation of health interdisciplinary research, and we want to continue that.
So, my first question, and I'll throw it to you and the others in our studio audience. What do you think are the fundamental keys to successful intellectual cross-dressing?
Well, as a non-expert, I mean, I would say that openness to being willing to step out of one's comfort zone and learn about and try to experiment with methodologies with which we're unfamiliar. But as someone who practices multidisciplinarity a lot better than interdisciplinarity, I've, over the long years of my career, been trying to make those steps into other disciplinary practices, like from literature to history. And it's not that easy. And when I see what this program is attempting to do, my admiration is all the greater for it.
I would say curiosity possibly would be the and I think also this sort of willingness to think about everyone as having the right answer is a good thing too. That when I started, even at UVic, we started in a large community alliance for health research, and there were qualitative researchers and quantitative researchers in the same, under the same umbrella, under the same grant. And there was a lot of disparaging across groups, that the qualitative researchers, you know, thought that the quantitative researchers were really too objective, whatever that meant, and the other side thought that the qualitative research was really not generalizable, so why would you be doing that? There was a lot of this sort of cross-disciplinary intolerance, I would say, which is not productive to learning, and it's not, this sort of turf issues are not always productive to learning. So the ability to kind of be curious across turfs, to not stand on your own turf too strongly, I think is a really key approach to the issues of
interdisciplinary program. So that's the tension that really exists between disciplinary programs and interdisciplinary ones. So strong foundations is one, and then I came up with these other two. So some people think interdisciplinarity is more like fruit smoothie. What do I mean by that? Well, it's the transdisciplinary move. It's the edges that one of our panelists, I think Bonnie, was talking about, that the innovation comes from the edges of disciplines and new knowledge emerges. So the fruit smoothie is the new knowledge. And there are interdisciplinary programs like Social Dimensions of Health that describe themselves as a fruit smoothie. There are others that describe themselves like a fruit salad. So what kind of a program might that be? I think of a program like, well, let's see, the combined degree in computer science and music. Both computer science and music are important parts of how students make new understandings of the ways in which technology can be applied to music. But they are separate components and parts that taste good when they're mixed together. so that we can make use of those different disciplines, but they're still treated as separate components. So it's really the fruit salad metaphor. So across UVic, we have them all. We have the strong foundations, we have the fruit smoothie group, and we have the fruit salad group. So I'm trying to bridge across those different things to come up with a definition. And this is what we've come up with so far. So it's a lot of words. But one of the things we're trying to represent is that all of our programs at UVic have an interdisciplinary thread. Every discipline has a thread of interdisciplinary to it. So I come from the field of education. It is inherently interdisciplinary. It has to be, because the field of education touches from, it comes from sociology, the social sciences, the hard sciences, statistical analysis. All of these things inform how we do these programs.
There's just lots of ways of doing things, and I like that about traveling internationally. The misfortune that I had was I traveled to Africa at a time when there was very little talk about HIV and AIDS, and contracted the virus myself. But I just was speaking at another conference to do with therapeutic touch, which is energy work, which is another whole area of study that I've invoked myself along the route to study. But there I was speaking for Africa, and I felt so un-African. This color of skin is not very African, and nothing about me seemed African, and then I thought the virus in me is from Africa. And so I speak from a place deep inside when I talk about Africa, and it is for sure a passion for me. I started an organization after returning to Africa about 10 years ago, and it's called Positively Africa, and we try and assist community groups to do the kinds of things that help people to live with HIV when there's not a lot of resources around. Now I'm going to talk about this piece here, and after living with HIV and AIDS for years, a group of pills were combined together, and they were called a cocktail. And I started taking the cocktail in about 1996, 96, 97, somewhere around, probably 96, I'm sure. There's tags in our lives, things that mark our lives, and my partner died very tragically in 97. And that's one of the tags in my life, is I can center things around that time. And I know it was before that time, because I started getting healthier. And I was destined to die. I was given a palliative care binder. I hope that none of you know what a palliative care binder looks like. But when someone is dying, the hospitals will look after them in any way possible, and they're given a binder to monitor the kind of care that they get. So I recovered, and after I recovered, started taking what's called a cocktail, and realized immediately that it wasn't a cocktail. I was taking 49 drugs a day, 49 prescription pills a day. And in order to take those 49 pills, my life didn't allow this kind of activity. I had to be at home, I had to have an alarm, I had to have food. At certain times, I had to have an empty stomach. At other times, I had to wake up in the middle of the night to take pills. That's no kind of life. And that's not a cocktail. And so for a long time in my head whirled around this idea, I'd like to build a big cocktail glass. I'd like to build it with people from across the country participating in the construction of it. And finally, I just decided I'm going to do it. There isn't the money coming from the Canadian Society to pay for such a thing. Do you guys want to sit? Yeah. So John,
we'll just lay it down there.
It's really hard to do that. So the cocktail glass, actually, if you want to see it, is at the Sukalali Pharmacy right now. The Sukalali Pharmacy is on Yates Street, just before you get to Cook. And it's just inside their lobby. You don't even have to go inside. If you look from outside, you can see it. And Suki is an amazing supporter of HIV initiatives. But I decided I was going to build this giant cocktail glass. I know a little bit about sculpture. I work with clay mostly when I sculpt, but this was totally out of my realm. So I had to talk to plastics experts. How do you adhere plastic to plastic in order that it will stay stuck together outside in the weather? Because this was part of an outdoor sculpture competition in St. Andrews, New Brunswick. And how do you create something as big as this? It's 7 feet tall, so it's huge. How do you create something this size and then take it apart so that you can set it up again wherever you go? How do you do the engineering around that? There were many, many things that I learned doing this sculpture. But then how do you put it in your truck and drive it across the country? Was my next problem. And so there were all kinds of people that were helping me to do this, including a family where the mother is a friend of mine that I've known since she was a little girl, and the father is a First Nations gentleman from Ucluelet. And so these people have combined many different ethnicities and ideas about how to do things, and they quickly put together a canopy for my truck so that I could drive it across the country. And I'm thankful. This is not a project that I could do on my own. I washed 2,000 pill bottles, but I didn't wash 2,000 pill bottles because friends came and helped me scrub the labels off pill bottles. Any of you who've made wine know how well adhered labels are to bottles or to pill bottles. I didn't want any information going out on who's taking these meds. There's a whole privacy issue. But I also wanted the stem of the cocktail glass to show the number of different medications that was part of the cocktail. And so I wanted the labels kept on those. So I just would black out names so that they would not incriminate anybody. We choose when we want to expose the fact that we're HIV positive. Somebody doesn't go and expose that for us. And then at the top of the cocktail glass, very important to me, I commissioned some women that I knew in Kenya to make me beaded ribbons, red ribbons that would hang from the cocktail glass. And that was my connection to Africa, where this pandemic is enormous. It's really where anything that we know about HIV is magnified 1,000 times. And unfortunately, it has the hugest impact on children. And so it either leaves children without parents, or it leaves children very sick without care. But that's one of the very sad realities about some of these things where, I grew up thinking it was women and children first, but it isn't. It isn't for sure in many, many parts of the world. So there was one other thing I wanted to talk about before I open the floor to questions. Well, the other thing that I realized really quickly when I was building this cocktail glass and taking it across the country is that there's a lot of garbage associated with the pharmaceutical industry, and it's not good garbage. There's all the residue of those pills in the bottles. So there's so many issues that came up for me just building an enormous cocktail glass that I never would have imagined possible. So I think the idea of studying health from an interdisciplinary perspective is really, really important, because the issues that come up are things that people never really thought about. When I drove across the country, I thought I would book into the next group. I stopped at 20 different HIV support groups across the country, and I thought I would phone ahead while we were driving. But there's gaps in the system where my cell phone wouldn't work. In this huge country that we live in, there's many, many, many places where cell phones don't work, and internet access isn't there, where the information isn't flowing the way it does at a university. And I think that that piece of information, all of a sudden it hit me, that's really important, because the kind of work that you're doing here at the university is wonderful, but we always have to remember that there's a bunch of people living in rural British Columbia who will never have the access to places like this and the information that these places hold. So I think one of your jobs is to make sure that whatever you learn gets out, not just to the community that's lucky enough to be here, but out to the broader community. So please let me get you to ask me questions, because I don't really know what will help you more to understand about this particular project. Am I crazy? This question? Yes. It took me 3.5 months to do that.
It was just a crazy picture in my mind. What about having your art next to the AIDS quilt?
Yeah, that was one of the things that, over a glass of beer at the end of a conference in Ottawa, I was talking to someone else from Victoria, and we really felt like the National Gallery needs to understand that HIV has had a huge impact on the artists in our country, in our world. And so I think that a piece, not necessarily this piece, but there has to be a piece of art in the National Gallery that reflects what's going on for the HIV community in the country. Thank you.
In your time traveling around rural BC and Canada, did you see like how knowledge was brought to those kind of communities? What kind of things they were discussing and how they were discussing it?
Yeah, we were so lucky. You know, sometimes I would plan things ahead of time, but often things would happen at the last minute. But one of the planned ahead things was a combination of the HIV community in Nelson getting together with the healing art. The words aren't coming to me, but it's art therapy, the art therapy community. And so they had this big meeting room that was an art therapy room where everyone got together. And so they were working interdisciplinarily to try and create the understanding for both communities of what HIV was. And one fellow in that group lived outside of Nelson, and he'd come into town and I'm really not going to do this. I don't really do these kinds of things. And there was a bit of food inside. Food is really important. And there was a bit of food inside, and so he came in to have a bite to eat. And then all of a sudden he got talked in, and the next thing, he's working away on the mural. You know, it's a way of getting to people. Isn't always to give them a book to read or to give them some material that you think is going to be really good. People approach health in many, many different ways. And I think for him, that was a huge leap from where he was alone, dealing with his HIV, to being part of a community. Another community that really embraced us was Thunder Bay. And we came into Thunder Bay, and they were so happy we were coming, and it just happened to be, it was Gay Pride Week, and they were raising a rainbow flag at the City Hall, and so we were invited to go to City Hall and talk at City Hall. But there was just so much that was going on that had to do with health and HIV that was aside from anything I would imagine. There was one fellow that was easily another foot taller than I am, and he was cross-dressed and wearing heels, and so he was 1.5 feet taller than I was. And he was going out and just telling people about every health issue that he could think of that had to do with gender and violence and stigma and everything that he could possibly talk about. He was talking about in that way. And he is a well-known figure in the North, so that's one thing. I also found out that although Vancouver is the only legal needle exchange program, there are needle exchange programs and other safety networks around the country to make sure that people have access to clean rigs if they're using drugs. And so that whole thing was really important to me. I wanted to understand a couple of things as I traveled across the country. One is, new science has made it incredible for people who are living with HIV, with the viral load controlled by medications. It's almost impossible for me to infect anybody. And that is a huge shift from when I was first infected, when I was told never to have children, never, almost don't have sex with anybody. There was just this don't. Just take your life and just squeeze it as small and as tight as possible. And now it feels like it's huge. It feels like anything is possible. People are having babies. Lots of HIV positive men and women are getting pregnant. And that whole thing is really exciting for me. And I wanted to understand how people were reacting to that across the country. Those are pretty personal questions. So I didn't get too far with that one. But the other one was, on the other side of that, was this criminalization of HIV that was coming in from the legal system, not understanding that HIV is controlled. That it isn't like, if I were to, I'm going to pick this guy back, here's not, it's good stuff. If I were to have sex with you, I'm not going to infect you with HIV. And so for you to charge me with, if I didn't disclose my status, failing to disclose my status, doesn't make any sense in our world today. And so that was another issue that I wanted to bring up across the country. And luckily, the legal network in Canada had made an incredible film that I was able to show and share that information. But some of the stuff around HIV is obviously, you've got Birch in your midst, so you know, it just makes you really passionate about the rights of people to make their own health choices in any situation, no matter what it is that they decide to do. They should be allowed to be self-determinant about health. Yeah.
And just to be clear about Peggy's point, because it might be new for some people, so scientifically it's impossible for a positive person who's undetectable, drug adherent, to infect somebody. However, for non-disclosure, even if they were to wear condoms, they would be thrown in jail up to 15 years.
and be labeled a sex offender for the rest of their life. So even though they're a successful model, we are successful models within this healthcare system, the criminalization is showing, again, from a social dimensions perspective, the attack on our work. And this is just one particular case study in the rights of women and all of these intersecting realities. Shane.
There's AIDS Vancouver has a really exciting campaign. Some of the pushback to this is their undetectable campaign. So likewise, someone had cancer, now they're in remission. They want to change the dialogue to say, I know I don't have HIV, I'm undetectable. And so they're trying to, obviously, we're affected by some of the legal ramifications. So within that movement, there is likewise this pushback to change our language, and by changing our language around how people with HIV describe themselves, right? There's been some really excellent research to really back this up, to say that, very longitudinal studies saying people serodiscordant, they're having sex, they're not passing it on, so government of Canada, fuck's your problem, move on. And so this sort of like changing how we describe, like by using terms like undetectable, we are pushing back against these really fear-mongering and really oppressive legal regimes.
Yeah. Until Obama took power in the States, no one who was HIV positive was allowed to cross the border for anything. So if I were flying to Central America through the United States, it was illegal for me as a person living with HIV, controlled everything, to go through the United States. So it's just the ridiculousness of stigma is quite obvious with this particular disease for some reason. And at the same time, I just want to report something else about health and HIV. They've taken the HIV virus and they've stripped the ability of it to target the CD4 cells. And they've made it so that it will target certain types of cancer cells. And they've used experimental treatments on children. The one case I know was a child who had some kind of blood cancer. And they used this virus that it has been so stigmatized and so deadly to cure this little girl's cancer. And I just think, yes, we're getting to the point, and it's because of interdisciplinary teams that we get to that place. People thinking outside of whatever silo they were raised in. I was raised in a silo, not a barn. That's my next answer.
Does anybody else have any questions for Peggy? You'll be around for lunch?
I'd love to stay for lunch. And my dear friend Mary is here too. Mary has known me since I was born. So she's visiting, so she's here.
And very proud of her, I am.
Okay, well that's great, and I'm happy to answer any questions. And the real thing is in town, so you guys can go look at it instead of this.
And if we could get some help to see if we can post this in the next room, that'd be wonderful. So thank you, everybody. We'll take time. Thank you.
And this thought just came from my fingertip, and the one previous to that from my duodenum. There is no mind in the brain bucket. The mind is the body, but it is not treated as such in our current medical model. The body is implicated in the negotiation of identity, sex, gender, sexuality, religion, race. It is objectified into a mental image of the self and others. It is the apparatus through which identity is implemented and exchanged. It is the way we are treated, socially and institutionally. What is liquid modernity? The neoliberal, post-Keynesian creation of the hyper-individual. The liquid modern is the individual who takes no shape, is not defined. The state no longer dictates who you are, only the parameters of what you can be. The medical industry is a solid and working within these rigid paradigms, and it must become liquid in order to diffuse among the liquid population and treat the mind and body as a manifestation of collective singularity. It must abandon the harmful oppressive practices fed by the corrupt hegemonic sciences, and the medical industry must, as per their oath of doing no harm, learn to treat the human under their stethoscope, not as an artifact of the white, ableist, hetero-colonizing patriarchy. The liquid modern doctor asks the patient, how can I care for you, rather than here is how I will care for you.
In Kenya, with a high number of parental deaths from AIDS, many youth have been left to head households.
caring for their own children, for siblings, and for ailing adults. Young women heading households are vulnerable to HIV infection, early pregnancies, and sexual abuse. This study explores how such young women in one urban and one rural area of Nakuru County experience sexual ill health and how they respond to suffering amid shifting systems of care in their social environment. I ask, how do young women who head households experience and respond to living with sexual health and fragmenting structures of care in their social
The goal of this project was to examine factors that may mediate the relations between social activity and cognitive function in aging. So based on the literature, vascular health, depressive symptoms, cognitive activity, and physical activity engagement were identified as potential mediators. And 2 longitudinal studies were included in the analysis, the Long Beach longitudinal study and the Victoria longitudinal study. Specific cognitive outcomes examined were reasoning, memory, fluency, and semantic knowledge test performance. A separate multi-level mediation shown in the diagram, multi-level mediation model was run for each study and within each study for each cognitive outcome independently. Multi-level mediation with longitudinal data allows the investigation of mediators at both the within-person and the between-person level. So within-person mediation is asking, for example, at occasions when people are more socially active than their own personal mean of social activity, are they at that same occasion experiencing better vascular health, for example, and in turn performing better on the memory test? At the between-person level, the question being asked is, do individuals who are in general participating in more social activities also in general participate in more cognitive activities, for example, and then in turn show higher performance on that memory test? So in all models, age, education, and gender were controlled for as covariates. And our results were different for the different studies. So I'll start with within-person results for the VLS study. So when VLS participants...
We conducted an action research project that involved about 100 participants living on a low income in Toronto who access services at 8 different organizations throughout the city. We held focus groups and distributed a questionnaire about experiences of getting around Toronto on a low income. We found that the cost of riding transit served as a barrier not only to transit access itself, but also had a detrimental impact on well-being as a whole. This project attempted to highlight voices and experiences that are disproportionately impacted by, yet are erased from transportation decision-making. We highlighted the experiences of those who are excluded from access to transit and the benefits that it provides, and also worked to mobilize that knowledge in a political advocacy.
At the Royal Inland Hospital, we work in a pediatric inpatient psychiatry unit. We provide crisis stabilization for the Interior Health Authority and the Thompson Cariboo Health Region. Our focus group of our study were 9 to 17-year-olds. Over 60% of our admissions present with a suicide attempt or suicidal ideation. They're unable to contract safe.
So a patient journey mapping exercise done in 2012 in Kamloops recommended quality improvement, education improvement in protocols and resources, and communication as strategies needed to enhance service delivery to our clients and their families. Responding to these recommendations and staff desire for enhanced collaboration, our project draws on Kutcher and McClucky's values of collaboration, continuity, and community. This project was initiated through evidence-informed practice innovations action research and the Thompson Rivers University School of Nursing in collaboration.
However, in cities around the world, the built environment is also being changed by vigilantes. Without permits or permission, citizens are painting bicycle lanes and crosswalks, they're planting vegetables in public parks, they're converting parking lots into recreation spaces, they're installing seating at bus stops where there was none, also known as bench bombing. They're creating and posting community walking maps. They're knitting covers over urban objects, also known as yarn bombing. They're opening pop-up shops and abandoned storefronts and turning vacant lots into gardens. These interventions and many others are known as DIY or guerrilla urbanism. And I would encourage you to Google these terms and you can find lots of wonderful examples. DIY urbanists are not content with lobbying for a better city sometime in the future, and they often refuse to wait for permission to do things differently. And DIY urbanism is both condemned as vandalism, because it's often illegal, and it's celebrated for contributing to healthy and socially just environments with tremendous efficiency.
Adam.
Adam.
Marion.
Marion.
Melody.
Melody.
Sherry.
Sherry.
Kate.
Ging gang gooly 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 watcha. Ging gang goo. Ging gang goo. Hela. Hela Shayla. Hela. Hela Shayla. Hela. Oh. Ging gang gooly 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 watcha. Ging gang goo. Ging gang goo. Ging gang gooly 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 watcha. Ging gang goo. Ging gang goo. Hela. Hela Shayla. Hela Shayla. Hela. Oh. Hela. Hela Shayla. Hela.
Ladies and gentlemen, this morning I walked my dogs.
Oh.
It's a big dog. Dogs miles.
Ladies and gentlemen, this morning I put my pants on one leg at a time.
I'll give you a third task. The third task is to try and think of a song that is associated with the concept that you've chosen. So, like, the second task, but I'm going to give you a third task. You guys are really I know. We're not going, we're going. We're practicing. Oh, okay. To the
So your term was wealth?
Yeah.
Yes, but non-monetary. 1, 2, 3, 4. Love, love, love. Oh yeah.
A very key component, this idea of playfulness. And I think that, like, pretty much a lot of what we said as different, like, okay, I invited everyone to come in and to make suggestions. I tricked you? I don't know.
Learn it into a comfortable place.
Comfortable place. Breaking down barriers, thresholds, groupthink process, some of those different things. I don't know. To me, kind of the anchor for all of it is that kind of playful energy that we were able to share together. Does anyone have any thoughts on that? You kind of pointed to that. We can get super theoretical if you like. That's very fun too. Yeah.
I think there's grief to playfulness as adults, as we mature, that there's a hidden grief that we don't acknowledge. Like even just talking about all those games stirs up what I would call that soulfulness. So within that, there's a